All right, so I'm going to start calling out the things that I'm finding as I'm working. So the first thing that I'm finding is, I would call this, I would say moderate plus adhesion in levator scapula on the left-hand side.
So L circle, M capital A lowercase d h for the adhesion. You always want to put the side, so L circle or R circle.
And then M plus, right?
Yep,
So
M
moderate
plus, moderate plus, ADH, adhesion.
Like this?
Is that pressure okay?
Put a circle in over just the L, otherwise it's right.
So there is some corresponding hypertonicity on the other side, but it's not dramatic like the adhesion that I'm finding on the left, so I'm not going to notate that. That's just kind of background tension. But I'm doing a little bit of linear friction.
And on your gingerbread person, you can write that same notation near the picture with an X over the spot.
Okay, the next thing that sticks out to me I would call this moderate hypertonicity, so of the scalenes.
So M for moderate, HT capital H lowercase t for the hypertonicity. Scalenes, is that the left?
Yep, left
So put the
scalene.
L in a circle first. L circle M, HT scalenes. And on the gingerbread person, the hypertonicities are 3 parallel lines on the, and I like to draw them where the muscle is, in the direction of the muscle. That way when you're flipping through charts, you can tell easier which muscle had that. It's not very useful if you just put them all in the same direction and there's the whole area is just hypertonic. It doesn't give you as much information when you're reviewing charts. Sorry, Elizabeth, I figured it'd be easier if
That is super helpful.
you're calling things out. You don't have to also help them with the
Thank you.
abbreviations.
My brain can only do so much, and you basically nailed its limitation. All right, so as I'm sinking into the scalenes here, the scalenes really want to release. They're not doing it very quickly, but they're like ready to go. And I usually take that as an indication of that, that's not really where the real problem is hanging out. But it is limiting, and it is going to affect the rotation of her neck.
And while Elizabeth's facilitating that release of the scalenes, what do you have to be really careful of when you're working the scalenes? An artery and what else?
The brachial plexus.
Thank you, the brachial plexus. So if Elizabeth was to compress the brachial plexus, what is that likely to feel like to the client?
Tingling, numbing.
Excellent. Numbness, tingling, or sharp shooting pain. And strangely enough, many clients will assume that we know what's best to the point that whatever we're doing is correct. So it's a good thing to let them know, let me know if you feel any numbness or tingling down your arms or in your hands.
Or if you see them all of a sudden just start like flexing their fingers a little bit, sometimes they'll feel it but they won't say anything. And if you start to see them like opening and closing their hand or shaking their hand, that's usually because they're starting to get a little tingling.
And if you just back off and move at that point and kind of flesh out the area a little bit, you'll be fine. But if you ignore that and just keep going, you could do some nerve damage. And the scalenes are interesting because their trigger points often also refer in all the way down the arms as well. So they may feel some sensations down their arm, and that's different than if they feel their hand going numb and tingling and sharp pain. That's your move, I'm on a nerve. But if they feel some sensations down the arm, you could just be on a trigger point. Does that make sense, or is there some clarification needed around that?
I have a question that's kind of related.
Yeah, sure.
What if they come in with, they already have nerve damage, like numbness and tingling?
That's a good question. You could clarify, oftentimes even in that case, it won't always be activated. So if you gain some clarity on how it is sort of as a baseline and what triggers it, that way you'll know the difference between their baseline and what you're doing. And nerve impingement can be pretty tricky even for Western doctors to really isolate and diagnose accurately. And so, that they may have impingement by muscles or bones. It could be different things. And we'll get to thoracic outlet soon and carpal tunnel and get into that in a little more depth.
So, since I work at a chiropractic office, one of my goals that I always have in mind whenever I have a neck case, because I know that they're going to be seeing the chiropractor either before or after me. So if they've seen the chiropractor before me, my goal is to help their adjustment kind of settle in and loosen those muscles so that it's not going to immediately snap back to where it was. If they're getting adjusted after the massage, my goal is to soften things up enough that they can get a really good adjustment.
Mm-hmm.
If you guys have ever had a chiropractic adjustment where it's only it only feels like it goes halfway, it's a horrible feeling. So I always try to make their adjustments a little bit easier and more effective if I can, by just loosening things up a bit. Now, one thing that I have noticed that we didn't assess earlier is that both of Carla's shoulders were pulled anteriorly. And as I'm releasing the scalenes, this shoulder is relaxing back into a more normal position. It's still a little bit forward, but that is a change that I'm noticing.
And those changes you want to indicate in your chart as well. Some of the leaders in the industry in regards to chart notes and with respect to insurance coverage, covering the massage or not, often say that one of the biggest problems with massage therapist charts is that they only note the hypertonicities, whereas we can really note the changes in range of motion and adhesions and trigger points and postural changes, functional changes.
So are you noting the fact that her shoulder was medially rotated, or are you going to note that it, I guess,
So I would note that both of her shoulders are rotated forward. And I would also note a change with that. And you can notate it by degrees, or you can notate it. You can notate it mild, moderate, severe.
And with regards to degrees, most massage therapists just estimate, but we can use the tools that measure these things as well, like goniometers, but most massage therapists just estimate.
All right, as I'm getting up into the occiput, I'm noticing quite a bit of hypertonicity on the right side, not so much on the left side. I would call this moderate on the right side and mild plus on the left side.
So what comes first when you write that down?
R.
Yep. And the R for right has a circle around it, so R circle. You said moderate plus?
I would say just moderate.
Okay. Capital M. And do you note that in a specific muscle or?
Oh, this feels like Splenius Capitis to me.
You could spell all the muscles out, or you can learn abbreviations or use an abbreviation chart as you learn them. So Splenius Capitis. Now you can note these changes in the fascia as well. If you should notice, it's say one of the fascial lines, or you can note specific muscles. And the one that you noted on the left, is that also Splenius Capitis?
Yes.
And that was low, or?
Yeah, I would say that's mild plus.
So the mild is a L, capital L plus. Now Elizabeth's gonna go over this again when she helps show you the chart notes at the end in the classroom. But just to be thinking as you're noticing where it started, you also want to notice where it gets to. And sometimes there will be zero change, or sometimes you may get from an M plus to an M minus, or sometimes even a 0. But the important thing is that you're honest. This is just going to help your future treatments to see what helped and what's still there. And some things will change a lot, and some things will change a little, and some things won't change at all. Notice how slow and still Elizabeth's work is in this area. It may not look like she's doing a lot to be that slow, but if you're really patient with the neck, you can facilitate a lot more changes.
And I want all of my neck treatments to feel relaxing. The neck is one of the places where people have the most trouble, like just really relaxing into your work. I would say the hands are the other spot. I want it to feel nice.
And remember that our client today started with an active headache. And how did she describe that pain?
Sharp
Sharp,
on the left side.
left side. Where did it start and go?
It was a little bit behind the eye and went like all the way down to the occipitals.
Excellent. So if somebody starts their massage with a sharp headache actively, how do you think that changes your approach to this session?
You probably want to be particularly gentle so you're not making it worse.
Yeah,
Excellent,
that's aggressive for sure.
excellent,
No jostling.
No bright lights, no loud noises.
excellent. And you might be surprised, or maybe you won't, but if you take those approaches, oftentimes the headache can change quite dramatically during the session and get a lot better or even go away. But it's certainly not the time to release trigger points in a more aggressive way.
Right now I'm just getting into the lamina groove on either side. Just because it feels a little stiff.
And this is great for all massage therapists, but again, remember Elizabeth mentioned she works at a chiropractor's, and when the chiropractor is going to adjust the vertebra, very much you want to make sure those multifidi and rotatories are relaxed as much as possible. And of course, that's what, if you get all the way into the lamina groove, that's what's that deep. But sometimes it's nice to not talk as much when you're doing massage, so I hope this isn't too much interjection, Elizabeth.
Oh, no, it's fine. So I am, as I'm sinking in here to the multifides and rotatories on the left side, I am finding quite, I would say a moderate adhesion here.
So how do you write that moderate adhesion on the left in the rotatories, multifidi?
Is it left or is it right?
It's on the left side.
Okay.
So what I'm doing with my hand is when I work on the multifidi and rotatories in the neck, I come in from the opposite side just because I can sink in and also pull a little bit against the spinous processes.
Right.
So how do we note what Elizabeth just told us she observed?
Capital O, circle, M, ADH.
Fantastic. On the, did you say rotatories multifidi or either?
Yes.
And it's probably impossible to distinguish between the two if you're being honest, so you can rotatories / multifidi.
Are there abbreviations for all of the muscles?
Pretty much, yeah. And I just memorize my favorites, or the ones that are longer.
Yeah.
And then a lot of places you'll work will have electronic software that has, boxes you can check.
Oh, that really
And are we recording the modality in response to right now?
It's good to note it, like if Elizabeth is using a lot of different approaches, to keep noting it, but if she keeps using the same one, you can add those later. Are you using linear friction for most of this, Elizabeth, or?
I would say a combination of linear friction and compression, and a little bit of petrissage.
So when you use the slow compression, it's PIC, capital P, capital I, capital C for prolonged ischemic compression. She mentioned a little petrissage. We don't have to list every Swedish technique separately if it's just the context of a Swedish massage warm-up. But if she's treating with it, you can then note it as the treatment. And the petrissage is lowercase p-e-t. Now this is an excellent practice that everybody is writing all of the notes that Elizabeth is saying out loud. You can see there's quite a few things she's observing and noting, and it takes some practice. What I would recommend is that really while you're practicing, you're saying these things out loud. In a real massage, you're not going to stop touching the person to take notes, but as you're learning, you could use your notepads to just actually take the note during, and you'll get better and better at remembering things. But you'll definitely want to note those things right after the session, because if you wait till the end of the day after 3 or 4 or 5 clients,
You're gonna mix
You're gonna
that.
mix
they'll blur together. You'll think you'll remember, but then
Right.
you'll be like, oh my gosh, was that one the right shoulder or the...
Right.
All right, so I have noticed a huge change with the multifities and rotatories.
And where would you say they're at now? A 0, a L,
I would say they're at mild minus.
So a mild minus is a capital L with a minus sign, like a superscript minus sign. Could you, I've been meaning to call this out. I'm assuming the right side looks the same. Look how soft Elizabeth's hands are the whole time she's treating. And she's supporting the client's head with the base of her hand, and her forearms are very relaxed on the table. So you just want to get as relaxed as you can with this work, support the client, and then it's very precise precision work.
Also, the more I relax my forearms on the table, the more I'm able to use my body weight pushing into my forearms like a fulcrum. All right, so here's where we get into the real meaty business here. We're right at the occiput. And when I transition to the occiput, I do one hand at a time, scooching their hair out of the way while I slip my hands under the back of their head. And I can also use my thumbs if I feel like it's a little bit wobbly. I can use my thumbs to stabilize. Because lots of times what will happen is that somebody will think that they are relaxing completely, but they're actually holding their head up just slightly, and it makes it so much more wobbly. So when that's the case, I will stabilize their head, remind them to take a deep breath, try to relax into my hands. Sometimes people will think that they've followed that direction and that they have relaxed their head, and they have not. If it's the case that they think that they've relaxed and they haven't, I don't keep reminding them or trying to cajole them into actually relaxing. I'll just meet them where they're at, because that may be something that they need some time to observe how their body responds to massage. Maybe they've never had a massage, maybe they're super anxious about massage, maybe they're just in so much pain that they can't relax.
Could you have them take a deep breath? Would that help them relax into it without realizing it?
Yes,
Okay.
sometimes.
Okay.
Sometimes you'll see people where you ask them to take a deep breath and they'll like move their rib cage as though they have done it, but not really.
Okay.
And sometimes, honestly, it's the massage therapist's fault. So you don't want to say, berating things to the client about how, oh no, you can relax. Because you might have actually given them an unsafe signal in the way you moved their head and triggered, right, if it was a car accident or, and we've got to balance these bowling ball heads on our spine. And so if you've done anything to disrupt the trust of the session, you're part of the reason of why they're not letting their head go.
Mm-hmm.
So that's why Elizabeth has these very slow, supportive, soft hands and very steady movements with the client's head. You got to gain their trust the entire time, and breaking their trust just once is really bad with the head.
Also, what can help, lots of times when I start out at the occiput, I'll use both hands, but especially if I feel like somebody's not able to relax all the way, I'll just do like one side at a time, curling my fingers up into the occiput, just sinking in there, because that kind of makes it so that they feel like at least half of their head they can just rest. So what I'm finding at the occiput, I would say, and it's the same on both sides, so it's bilateral. I would call this moderate plus hypertonicity at the occipitals.
So what's the chart notation for that?
Is moderate at the end?
Yes.
So M plus.
Mm-hmm.
Well, bilateral though. It's BI or
BL.
BL.
Capital B, capital L with a circle around it. So the location comes first, BL, circle first, and then the capital M plus. And in what muscles?
The occipitals. Don't feel like I'm deep enough to know what's going on with the suboccipitals yet. There's a lot of tension here.
And what treatment are you using?
I would call this linear friction.
Now remember, we have an active headache. What would be the most aggressive type friction?
Cross fiber.
Cross friction?
Cross fiber, excellent. So do you think we want to do that right now or no?
No.
Excellent.
Does the treatment go under the O with overall treatment, or does it go under like modality?
So the modality would be like compression, Swedish massage, trigger point release, or MFR.
And you're doing compressions right now?
Right now I'm doing more of a like really